very well capable of controlling that and help the children not go into a blinding condition like RD, CNVM, and glaucoma. So let's go into the theories and etiopathogenesis of myopia progression. That is my topic today, understanding the myopia progression. So we all know this, that education, economics, electronics, environment, along with genetic factors, go on to that myopia, or the prevalence of the myopia increases because of all that. But how exactly does it happen? So first and foremost, there were animal models for conducting the to study the myopia, how it progresses actually. They were form-derived myopia model and lens-induced myopia model, where you put a diffuser or a lens in front of the eye, and they study how the defocus actually affects the axial length elongation. So if you put a minus lens in the developing eye on chicks or tree shoes or monkeys, they noted that axial length elongated because the rays were focusing behind the retina, and that gives a stimulation, and vice versa if you put a plus lens. So that is the first theory, the feedback emmetropization. That is how it came, the first theory, along with all the studies. So when there is a visual stimulus defocus, for example, it can be myopic or hyperopic, but in myopic cases, it is hyperopic defocus. There produces a retinal response, and that leads on to a communication to the sclera, triggering a remodeling on the sclera, which affects the axial length elongation. Similar action is seen when there's an accommodation lag. It produces a hyperopic defocus as well. So that's the first one, and that is where the role of low-dose atropine comes into being. It has actually dual mechanism of action. So it has an action on the retina as well as sclera. Retina, where it targets the neurochemical cascade to just inhibit so that there's no tendency for axial length elongation. And on the sclera, it's actually affecting the glycosaminoglycan synthesis, which affects the extensibility and fibrous component. So that's the basic action, but further, Dr. Gigi Augustine Madam will be speaking more about it. The second theory is the peripheral hyperopic defocus. So what happens when a basic concave lens is put in front of the eye? The central rays are correctly getting focused on the retina, but what happens in the periphery? The peripheral rays are getting hyperopic defocus, and this has been very well studied by Earl Smith's experiment is proven. So that is where the novel spectacle lenses are being developed to counteract that. So the hyperopic defocus has been controlled by the novel specs while maintaining the clear central vision. More of that which our dear Monisha Madam will be speaking about. The third theory is the role of accommodation. That is what I said in the beginning of the hyperopic defocus. So when there is an accommodation lag, it provides a stimulus for hyperopic defocus. Accommodation lag is equal to hyperopic defocus. Again, it goes all to that neurochemical cascade where the retina communicates to the sclera, and that provides a stimulation for axial length elongation. So when a child who's got already an accommodation lag does a lot of near work because various factors as shown here, it will again lead to axial length elongation. So that is why the importance of lifestyle modification comes into play. And also there's a big role on reading in bright light. So what happens in bright light is that when the child is reading a book in a bright light, meiosis happens, thereby increases the depth of focus. So that can actually compensate for the little bit of accommodation lag that the child already has. So that is again another importance of the bright light. The fourth and the last theory is the light dopamine mechanism, where a quantity and the spectrum of the light has a very big impact on the axial length elongation. So when a particular type or amount of light comes into the retina, the intrinsic photoreceptor retinal ganglion cells gets activated and dopamine just releases. And that dopamine release acts on axial length reduction along with increase in choroidal thickness. And that is where the novel treatment right now comes into play. The light therapies, red light and the blue light has come into play, along with the importance of outdoor activity here you can see the outdoor light is around 10,000 lux versus the indoor lux is around only 500. So you can't even compare the benefit of outdoor activities. So nevertheless, whatever it is, when you see a myopia case, these three cardinal things should be counseled to the parents as well as children. The importance of the increased outdoor time, at least more than 14 hours plus per week. High indoor ambient lighting while reading, as well as frequent break. 20-20-20 rule is a must. It should be followed very religiously. So the billion-dollar question, when to intervene? So that is by risk stratification first and documenting a myopia progression of more than 0.5 diopter per year. So high risk means when there's a larger baseline refractive error, younger the age of onset, who has a parental refractive error. Basically, if the both parents are having a myopia, there is a 3 times chance for progression as well as prevalence for the child, and also very poor visual environment situations. So you understand what is, you stratify the children, identify if it is a high risk or low risk, and follow up documented progression more than 0.5 diopter per year, we start the intervention. What are those interventions? It can be pharmacological or optical interventions and more. So that will be dealing with right now in our session. So first I really call upon Dr. Gigi Agustin Madam. She's the Assistant Professor at Amala Institute of Medical Science. She'll be dealing with low-dose atropine. Thank you, ma'am.
Good afternoon, everyone. First of all, let me thank KSOS and Dr. Tanushree for giving me an opportunity to present this topic on low-dose atropine in controlling the myopia progression. So, what we know so far, we have enough scientific evidence, multiple clinical trials showed positive outcomes. Now it is an accepted treatment for the myopia progression. And 53% of the eye care practitioners prefer LDA as the first line management. So coming to the RCTs, the ATOM studies. In ATOM 1, they tried 1% atropine and showed that it is effective in controlling the myopia progression, but had unacceptable side effects like mydriasis and cycloplegia. And in ATOM 2, they compared the efficacy of 3 lower doses, that is 0.5, 0.1 and 0.01% atropine, and it was found that 0.01 was as effective as 0.1% and had least side effects. Greater rebound progression was noticed after stopping higher concentrations. Then came the lower concentration atropine studies, that is the LAMP studies. In LAMP 1, they compared further lower concentration, that is 0.05, 0.025 and 0.01%. And it was found that all concentrations were effective without much side effects. And 0.05 was the most effective in controlling spherically equivalent progression and axial length elongation. And in LAMP 2, they compared in non-myopic children between 4 to 9 years to evaluate the efficacy of 0.05% versus 0.01% atropine in the prevention of future myopia occurrence. And it was found that 0.05% atropine resulted in significantly lower incidence of myopia and fast myopic shift compared to 0.01%. Recently, there was some conflicting results regarding the effectiveness of 0.01% in American children. That is, there were 2 studies showing conflicting results between no efficacy and good efficacy. That was in American children. But there are numerous Indian studies which most of them reported with favorable results. So coming to the mechanism of action. The exact mechanism is still not known. It acts via muscarinic receptors at the posterior segment by influencing the local pathway at retinal, choroidal and scleral level. So mainly three actions, that is release of dopamine, inhibition of scleroblast, and increasing the choroidal thickening. All this finally inhibits axial length elongation. Whom to prescribe? That is myopia progression more than 0.5 5 diopter per year between 6 to 16 years of age, astigmatism less than 1.5 diopters. And where it does not work, pathological myopia, lasered ROP children, and index myopia. So contraindications, there are only relative ones, that is Down syndrome, heart diseases, etc., severe heart diseases, etc. And side effects, these are only temporary minor side effects like temporary stinging, blurred vision, sensitivity to light, etc. So how to start LDA? First of all, you need to counsel for a long-term use of LDA to the parents and the child. Take certain baseline measurements, cycloplegic refraction, axial length, and keratometry in addition to the routine tests are a must, and record these in every follow-up visits. Prescribe atropine 0.01% eye drops, 1 drop at night both eyes, and follow up every 6 monthly. Inquire about compliance each time, which is very important. So when to stop atropine treatment? So when there is no progression for 2 years, a treatment period of 2 to 3 years is acceptable, and even up to 5 years is found to be safe in different studies. After stopping the drug, close follow-up is required to document any rebound myopia progression, and tapering should be considered before stopping the drug. There could be non-responders, that is increase in myopia more than 0.5 diopter per year even with the treatment, and there are 10 to 20% of non-responders. In rapid progressive myopia, there will be increase in myopia more than 1 diopter per year even with the treatment. How to manage them? Increase the frequency to 2 times a day, or switch to higher concentrations of LDA or other treatment modalities, and even combination therapy with other modalities of treatment. Recently, ARM study, that is 0.05% atropine for rapid progressive myopia by Dr. Rohit Saxena et al. Was recently published in 2025, showed 62% reduction in the progression and with no side effect, adverse effects, with 0.05% atropine. Now it is commercially available in India. And a concept of pre-myopia was introduced by IMI, the International Myopia Institute. These are children who are not myopic at the moment, but they have a sufficient likelihood of future development of myopia to merit preventive interventions. Who are these children? Like they have a refractive status between less than plus 0.75 diopter and minus 0.5 diopter. They will have some quantifiable risk factors like baseline refraction, age, as Dr. Thanos told, and other risk factors like ethnicity. Asians are at higher risk, and a positive family history, that is if for parents and siblings, if one parent is myopic 2 times, and if both parents 3 times chance of developing myopia. And unhealthy visual environment, that is more of near work and less of outdoor activities. So managing pre-myopia is more important than controlling myopia progression, because we can save the child from becoming myopic and its complications. So treatment of pre-myopia, close follow-up every 6 months, environmental modifications, outdoor activities, outdoor activities for more than 2 hours per day, reduce near work, 20-20-20 rule, etc. And low dose atropine can be considered only in high risk cases. So to conclude, LDA is the most documented and accepted intervention for control of myopia progression and also in delaying the onset of myopia in pre-myopes. It is relatively cheaper, easily available, and with almost no side effects. Both 0.01% and 0.05 are commercially available now. Tapering may be needed as rebound myopia progression can happen, especially after stopping the higher concentration of drug. 0.05% LDA alone or in combination with other interventions can be explored among non-responders and rapid responders. There are still few unaddressed questions, that is how long the treatment can be continued, what's the long-term efficacy and adverse effects of 0.05 versus 0.01% atropine, management of rebound progression, and how to taper before stopping, how to record the compliance. It's very difficult to record the compliance of the patient. And there is a national consensus guideline given in IJO 2023. Thank you.
Thank you, ma'am. We'll have a discussion later. Next, I call upon Dr. Monisha Mohan, consultant in pediatric ophthalmology in Strabismus, Ahilya Eye Foundation, Palakkad. She will be speaking on spectacles, contact lenses, and even more.
So thank you, Dr. Tanu, for including me in the IC and KSOS for the opportunity. So we have young children, very fast progressors and very high myopia, and many parents don't want to give them drops. So they ask us, what are the other options? So here we have glasses, contact lenses, and newer therapies with us. So coming to the myopia control glasses, so from 2018 onwards, we have had various myopia control glasses like the DIMS, and it is commercialized as Hoya MyoSmart. The Halt lenses, these are by the SLR group, and the Care is by the Zeiss MyoCare. And we have newer technologies and newer myopia control glasses such as DOT, that is by the Single Vision with the diffusion optics technology, and the Larry lenses, very recent one in 2024, where there are positive and negative lenslet array integrated spectacles. So let's look at them one by one. So coming to the DIMS lenses, so all of these lenses have a central clear area where it corrects for the distance vision, and then surrounding in the mid periphery there are about 400 multiple defocus segments which are 33 mm in diameter, and they are arranged in a honeycomb pattern, and each provides a plus 3.5 add which will control the myopic blur. Okay, so it converts the hyperopic defocus into a myopic defocus. Coming on to the Halt lenses, so this pushes the concept even further. So what happens is there is a shell of a myopic defocus that is created in front of the retina. So again, this has around 11 concentric rings and formed by 1021 contiguous aspherical lenslets. So in between you have the distance correction. So it creates a volume of myopic defocus. And coming to the Care, so these are cylindrical annular refractive elements. So here you have alternating defocus and correction zones in a ring-like pattern. So it again clears a blur effect as like a competing defocus, and that again causes a stop signal for progression of myopia. So here you can see that there are circular rings, and the ones that are elevated have a +3 lens, and in between you have the distance correction. So coming to the newer generation, so this is very interesting. So this is the DOTS lenses, so diffusion optic technology lenses. So here what you can see are these micro diffusers. Again, the central one corrects for the distance vision, and surrounding what you have are these micro diffusers. So these will reduce the contrast. Okay, so it is based on the contrast theory of myopia. And so just like how outdoors are helping for reducing myopia, similarly this is kind of incorporated into a lens, and this itself will reduce the contrast, and this will work while the child is still indoors. Okay, so this is the DOTS lenses and the Larry lenses. So here again you have a central clear aperture with alternating treatment zones. So here what is interesting is what they have found is you have positive and negative. So there is +3 and -3, and there has been a comparison between the two. So what they say is actually both of them reduce myopia, and there is no significant difference whether you're using a plus or a minus. So this is again, these are the Larry lenses. This is yet to be studied. The study has been started in 2024. Okay, so comparison between these lenses, that is the Hoya Smart, SLR, Zeiss, and Sight Vision. So all of them approximately they reduce, and the efficacy is about 60 to 70%. So the DIMS, Care, and the Halt lenses aim at reducing the hyperopic peripheral defocus, and the DOTS will reduce the abnormal contrast signaling in the myopic retina. There's also an asymmetric lens design where in the nasal retina you have +1.5, temporal there is 1.8, and inferior there is +2, the very little information about these. So coming to the Indian studies, they have compared the DIMS, HALT and CARE by the AIMS group. So here they have found that the DIMS and the HALT perform better than the CARE spectacles. And Sandra ma'am and the group have done a study with regard to myocare lenses. So they did well compared to the single vision glasses. So if you see all of these, all of them did initially very well, and gradually the efficacy reduced. So this is probably because of neural adaptability in the retina as well, which is going on. So even the LDA, even the glasses, everything do initially very well, and gradually the efficacy kind of dims down. So these are the evidence-based insights. So presently DIMS and HALT are the best efficacious, and all the three designs are safe, well tolerated. So it's a non-invasive option, 50 to 70% efficacious, can be used between 6 to 14-year-old. It is safe, it is alternative to the other therapies. Again, cost is an issue, but actually when you look at the long term, when these children actually develop a high myopia and the cost regard with that, it's I think a win situation here. And again, they can have contrast issues and initial distortion, and they work better with lifestyle modifications together. Even though the power does not increase, if there is scratches and breakage that when the children are wearing, then again we'll have to replace them. So that is again of concern. The moment they have scratches, it reduces the efficacy. So coming to the contact lenses, so again there are contact lens designs. So one is the concentric ring design. The most famous one is the MySight, which is not available here, but it is the only FDA approved contact lens. So it works on the principle of stepwise myopic defocus. Then we have the progressive additional lens design. This creates a smooth gradient myopic defocus, like more plus to the less plus, and then the extended depth of focus, just like you have in the IOLs. So this is available in India, and it is branded as SEED, and it's the EDOF lens. So this is through aberrations. So it definitely, like any other contact lens will do, it has given a better visual quality. It is ideal for active children who are into sports, and myopia control option definitely, because it is efficacious up to 40 to 60%, confidence and cosmetic boost, and it can also incorporate toric designs as well. And superior myopia control is observed with higher AD. More AD means more defocus, and concentric ring design is more efficacious than PAL. That is because it is more studied than the PAL, and the patients who actually wear, they should be adherent, whether it is the glasses or contact lenses. So if they are wearing it and they have good clarity and experience with it, then it works well. So coming to the talk of the town, orthokeratology is gaining so much popularity. So initially these lenses were available 25 years ago, but they were used as a tool where you could make the child glass free in the morning. But right now, and then when they started using it, they realized, okay, it is also slowing the axil length. So that's when the Ortho-K was introduced as a myopia control tool. So before the lens wear, what happens? So before the lens wear, it is normal. So after the moment you wear the lens, it kind of presses the cornea, flattens the cornea out. And then when you remove the contact lens in the morning, it takes some time to come back. So that is when they are spectacle free. So this is how the Ortho-K works. So when the child applies the contact lens, there are 4 curves that is produced. So this is the center part, that is a flat curve that corrects for the distance correction, and then there is a second curve. So that will act as that is what is controlling the myopia. So when the cornea is pressed, the lens epithelial cells kind of is pushed away along with the tear film reservoir which is present in this area. So this will act as a tool to control myopia. And after that is the alignment zones. Alignment zone makes sure the lens is stable and centered. And the last one is the peripheral lift edge, and that area kind of lets the oxygen to the tear film and the oxygen to be permeable. So this is how the modern Ortho-K lenses are designed. And there are better designs, and it's made of good materials, and also people are more aware of how to use it and how to dispense these lenses. So it's based on the reverse geometry lens design. Central base curve is flatter, and treatment zone. So there are smaller treatment zones, increases the defocus, but it comes with the cost of reduced contrast and visual quality. And the materials allow high oxygen permeability right now, and there is customization when it comes to astigmatism and toric in the peripheries, and also available for higher refractive errors. So it has a strong evidence, 30 to 60% reduction. Efficacy again tends to be stronger in the first 2 years, and then smaller treatment zone is now found to be better, and it can be combined with other therapies like atropine. So ideal candidate would be between 6 to 12 years and suitable up to -6 and -2 cylinder. And for people who don't want to wear contact lenses or glasses, and regular follow-up is very much necessary. You need a corneal topography to be done serially, and definitely cost. A pair would cost right now up to 40 to 50,000. And infrastructure and availability, the optometrists and the optometrists and the ophthalmologists should be very experienced with the ortho-K fitting. So coming to the newer advances, so we have the red light therapy. So this is based on the fact that increased light exposure can slow down the myopia, and here we have an artificial source. So it a low intensity red light, about 650 nanometers, which is handheld or tabletop, and 3 minutes per twice a day in the children. It is device based and parent and child friendly. So 60 to 70% reduction is seen, effective in both mild and high myopia. And definitely see the problem with this is the after images, which is present in less than 5% of children. But recently there was a publication in 2023 where there was a retinal damage after the use of red light therapy. So after that, somehow people are a little more this thing when talking about red light therapy. And this is most of the studies have been done in the Southeast Asian population and not in the Indian population. So very few pilot studies have been done here. So there is some more time, and again, rebound effects are a problem here. So apart from that, we have the optic nerve head stimulation and blue light therapy for myopia control, and also the ultraviolet rays light for myopia control. So if you can see in this chart, amongst everything that has been compared, the control glasses, the soft contact lens, ortho-K, atropine, and if you see red light therapy in the first 1 year, it reduces axial length elongation the maximum. So this is done only for 1 year. We don't know what really happens beyond that. So Gigi madam was talking about pre-myopia. So actually DIMS and HALT can be given is what they say, but to a child who does not need glasses, you cannot ask them to wear glasses. So that is very debatable. And so there is also a relation between myopia and binocular vision anomalies. So Dr. Tanu was talking about how accommodation is associated with myopia. So right now, based on the NRA, PRA values, after doing all the binocular vision tests, we can kind of get to know how much of AD is actually required for the patient with myopia. And so this is with regard to myopia and binocular vision. So if there is a normal binocular parameters for the patient, you can use any of these. But if the patient is having poor versions, then contact lens with vision therapy is required. If there is a lag of accommodation, we can't be giving atropine because it causes further lag. So you'll have to give bifocals or progressives along with vision therapy exercises. If there is a high AC/BI ratio, you can give progressive bifocals or LDA. If there is an intermittent XT, you cannot give glasses, because for the glasses to work, your eyes has to be straight. So in that case, you'll have to give prisms with single vision and add an atropine or ortho-K, and vision therapy has to be started. Again, for your intermittent ETs, we can go ahead with progressives and vision therapy. So tear film biomarkers is being studied. Imagine picking a child with just testing the tear film and finding out if the TNF alpha and the ICAMs are elevated. So it helps us to pick up progression early, intervention early, and monitor therapies. So again, there are treatments based on choroidal thickness. So thinner choroid is associated with higher risk, and so even OCT-based risk stratification can come. So we know one size does not fit all, and see all these for the myopia control glasses also. This has ideally both the sides, the nasal and the peripheral temporal retina, is said to have the same kind of configuration. But in a few Indian studies, it is found that the nasal retina is more myopic than the temporal retina. So when that is the problem, we don't know whether these glasses, or we'll have to formulate our own kind of glasses which are suitable for our population. And in spite of doing any of these myopia, testing whether there is a hyperopic defocus, myopia control glasses still remain effective in about 80% of the patients. Early pre-myopia detection enables timely intervention, and we'll have to optimize designs considering the binocular vision and the retina profiles of the patient. And combination therapy is becoming a boom, because we can combine if the child is not, especially for the ones who are progressing despite monotherapy. Thank you.
Thank you, madam. Because of paucity time, we'll go ahead with the next presentation by Dr. Meena Sikki, madam. She's the senior consultant, Little Flower Angamali. We'll be having an interactive case-based discussion. Over to you, madam.
Good afternoon, everyone. And I'll be going through a few case scenarios. And if time permits, we can have discussions. Otherwise, it could be boring also. So, what is happening now? Like, all the parents were quite peaceful with giving a screen or a tab to a child, and they could rest in peace. But now it has become, everything has become ulta. And now what we advise is something like a Gurukula Vidyabhyasam, where they have to go into the sunlight, you have to be outdoor for 2 hours. So the life has become very difficult for parents actually after all this. So these are the main things that we have to prevent myopia progression, like lifestyle and environmental changes. And as mentioned earlier, you have the pharmaceutical agents and the optical measures with which we can prevent progression. So I'll be talking about a few cases, and if time permits, we can discuss about it. So I've just divided my cases into pre-COVID, COVID, and post-COVID, and I was never aggressive with all these myopia progression measures, and I was always little hesitant to start all the drops, the glasses, etc. in the beginning. But now, obviously, we know that after the COVID, the things have changed a lot. So this was a 9-year-old girl who came to us in 2017, and she had a history of using glasses for 4 years, and it was from a nearby optical shop, and her mother was a myopic. And you can see most of the children who come to us, they will be undercorrected. Here you can see the child was using 0.25 and minus 1.5 sphere, and we did a cycloplegic refraction, and glasses of the correct power was given. So immediately I did not start on any measures, just gave the glasses, and this was in 2017. So then the child came once, and it was okay. And in 2019, there was a progression to -2 and -3.25. Started on low dose atropine. During this was a second or third visit, we started the low dose atropine. Then obviously the COVID started, and most of the patients, when they come even after 6 years, they will say it was COVID, so we couldn't come. That is the usual we hear from the parents. So this was from 2020 to 2023. There was no follow-up, and obviously they would have stopped the medications, and there was only a 2 diopter jump in 6 years. Like here you can see it is -3 and -4, and we started her again on the drops. She was on irregular medication, and we restarted on the low dose atropine. So this is a girl from 7 to 13 years we have been seeing. It was only a 2 diopter increase and on irregular medication. So I was always apprehensive, like whether you have to give drops for all the children. There is a natural progression of myopia which was happening earlier. So this was not a very high rise, but still, since we have all these drops and glasses now, we are giving, and after the COVID, the things have changed. So what is your opinion, Dr. Sandra, in this case? Now the child is 13 years. We'll continue with the drops. It's been so many years now.
So this is a common scenario we encounter,
Yes.
because many children during that COVID period, they have lost to follow-up. And now that the complaints to the drops is also not sure during that period, and we have seen a 2 diopter increase. So irregular medication, either currently, do you have the action length documentation?
No, we didn't have that time, the axial length
so once
documentation.
if there is a possibility, we can judge that, because more than the power, the axial length will give earlier indication. But since that is not there, either combined approach can be tried.
Okay. Many of them, they won't opt for the glasses. When they go to the optical shop and see the price, they won't opt for the glasses. That is one problem.
Otherwise, you go for a higher percentage, provided
now
you
we can go for a higher percentage.
Yes, right now. And you give some like a card or something for judging their compliance. You can give some other pointers, some regular reminders, or closer follow-ups to the patient.
So coming to the next case, this is a 7-year-old boy using glasses since 9 months. So actually the grandparents had brought the child, and it was in May 2018. Obviously the child was undercorrected. It was -1 power in the glasses, and then we did cycloplegic refraction, gave glasses, and as the child was planning to go to UK to join parents, I started the child on low dose atropine. Anyway, there was a -1 difference in both the eyes. Started on atropine. But the child didn't use actually. He couldn't go immediately, and though I prescribed, the grandparents didn't buy, and they came after 3 months, and in 3 months there was a progression. So they said, okay, we'll use the drops now, and on drops there was a mild progression. I saw the child again in 9/2019, and you can see the difference. It was -2 and it has become -3 and -4. Maybe they were not using the drops properly. And 2020 the grandparents came for prescription. The child was in UK. So we didn't see the child after that. And in 2022 you can see the progression. It has become -8. That is after that COVID time. So they came in 7/2022. This is in 2023. And they were using Myopia glasses by that time. They already came with Myopia glasses. And we asked them to continue the drops also. And now it is, maybe it won't grow more. It is like -8 in both eyes. So we saw the patient again in last of 24. And in 1 year it was stable with Myocare. We had asked them to continue the drops, but they discontinued. But now the child is almost stable, but the power has increased so much, like -8. And Monisha, you have anything to talk on that? Anything because we couldn't do anything different, child was not there.
Probably we can start on combined therapy, ma'am.
It's on combined now.
And or increase the dose of the atropine. Yeah. So
in next visit, if there is any progress, maybe we can increase the dose of atropine.
But that much of a high jump in the myopia,
6 diopters.
6 diopters. We should really look into the axial length and the lens thickness.
Axial length is there actually. I didn't. But the initial one I didn't have, so there was no point in putting it. So maybe now we will follow them. Yes. And the next one is a 7-year-old girl seen in July 2018, and that was the first visit, and we gave glasses. And reviewed in 3 months, and she was fine. And close to 1 year, approximately 1 diopter change. And I started on topical medications. Until May 2020, she was stable. And in December, she had a sudden progression. Like started with 0.75 and 1 and went to -3 and -4. And she has been using drops. They say they have been using drops continuously, but there is a progression. So we made the dosage BD. And again there was a jump in mid-2023 on to 2024. You can see it's quite high, -5.5. It has become, this is the last follow-up. And now it is more or less stable with BD dosage. Since 1 year she has been on BD dosage. But there was significant progression. So continuing with BD dosage. Maybe we can increase the concentration now. Gigi.
Now it's almost under control, no? The second.
It is now 1 year control now.
Yes, so continue the same, and we close follow up, and if
that is what we are planning to. So she is now 14 years. We'll continue with the drops. That is what is we. So this is all started before COVID. Now coming to the COVID things, we have follow up less, but we know what to do now. So this 11-year-old male came in December 2020. There was no history of spectacle wear, and main complaint was in the left eye. So he had just a simple myopic astigmatism in the right and a combined one in the left. And we prescribed glasses, and there was progression in 9 months. That was a peak COVID time. Then we started on drops, and here you can see he developed a myopia, simple myopia in the right eye also now. And the left eye from 2.5 it has gone to -5. Maybe availability of drug was not there that time. And he was stable for about 3 years with continuing medication. And you can see the sudden progression. Like started with -2.5, went to 5, and now it is progressing. Mainly in the left eye it is progressing. And the right eye it is almost stable with -1.25. And here we have the axial length, like if we have an axial 21 we had taken and 25, and it was 0.4 in the right eye and 0.8 in the left eye. And we added peripheral defocus glasses also. And this is the summary, like 11 to 16 years, right eye is maintaining 1 to 1.25, and axial length is 0.4 and 0.8, and medication continuing. So I was thinking, like, can we do all these treatments unilateral? Even glasses, what is your opinion, Dr. Sandra? Like all these defocus glasses?
Yeah, right now the child is 16 years old.
16 years.
Right now the axial length shows, what is the change in the axial length in the last 1 year?
1 year we don't have actually. From 21 to 24
Yeah,
and
so
we have.
the thing is, it won't progress in the same pattern. So
that's it.
when you have the axial length stability, I think it's premature. You can just see within 3 months what is the axial length. If right eye shows exactly the same axial length, then you can stop one of the interventions. If they don't, a better thing will be to stop the glass, because then they don't have to buy the costly glass again. So you can.
And do you think that always this axial length will correlate with the diopters?
No.
It
will
doesn't.
not correlate.
It doesn't
Especially
correlate.
in a higher myopia.
So it's not always you can depend on
You will
that.
have some idea. Like you are having two things, both spherical equivalent, and you are having the axial length. But it will not exactly correlate.
Okay. So now we'll go to post-COVID. It becomes shorter then. This 10-year-old female, seeing they have been seeing elsewhere. Again, you can see the correction they are using is less. So it's almost double now, the power. And she has been using glasses for 4 years. So immediately we started on dual therapy, both drops as well as glasses. Father is a high myope, so we didn't want to take any chances, immediately gave. And this 6-year-old, again in 2023, right eye is amblyopic, like you can see the vision is only 612, improving to 612. Started with 636 to 624, became 612 in 24. And she was not regular with amblyopia therapy, and we counseled well, and then they started adhering to amblyopia therapy. And 1.5 years, no significant progression, but you can see in 6 months, vision improved along with myopia progression. So the diopters has also increased, and her vision is also increased. So now she is on glasses. I'll stop now. Time is up. Okay. Thank you for your question.
Thank you, ma'am. Next, we have the keynote address by Dr. Sandra Ganesh, ma'am, Senior Consultant, Pediatric Ophthalmology and Strabismus, Head of the Visual Rehabilitation Center, Aravind Eye Hospital, Coimbatore. She'll be speaking on how to set up a myopia clinic in your routine clinic practice.
Thank you, Tanu, for the invitation, and I'm very happy to be here. So this is the last talk of today's session, and I'll be talking about our experience of establishing a myopia control clinic. So definitely we'll be touching upon few of these aspects here. Public health importance, as everybody has highlighted. Implementing into clinical practice, everybody has almost done it now, because looking at the load of myopia, and we have been looking at various guidelines for atropine and glasses and all. It's all evidence based practice, and choosing the strategy for each patient is definitely important, because it's a case by case scenario. General guidelines are definitely there. Compliance is something to be stressed, whether you talk about atropine or glasses, mainly the lifestyle modifications, because that is not done, then it's not going to improve. So you need a lot of discussion with the parents and the patient, and also something on marketing the control of myopia. So this is just one simple example of one day in myopia clinic in 2024. I had made this slide. So that particular day we had seen 67 patients in our myopia clinic, where 32 of them had brought single vision glasses newly, 8 of them were on review, and 10 of them bought myopia control glasses new. We have not yet started contact lens options or orthokeratology in our clinic, and low dose atropine review was 4. So as it is now, even the most common management is the single vision glasses for myopia. So that needs to be stressed, that we cannot replace everything with the myopia control strategies. Most of the time so we need to look at, so why was it not given, whether maybe the indication is not there, maybe they are coming the first time. So without documented progression, we will never start on a myopia control strategy. Because you start unnecessarily, then you will be looking at rebound and so many other things, the cost effectiveness, whether it is really necessary or not. But was this the beginning? Like even now we are seeing even more than that in the myopia clinic. So the beginning was definitely compared to pre and post COVID numbers, we saw the need for setting up myopia clinic as a separate entity even within our pediatric clinics, and I think that's the same with all the people who have talked today and even among the audience. So what we saw was there was definitely a higher number of new myopes being diagnosed post COVID. This was not just a lag in the people coming to the hospital, it was a sustained increase that was being seen. So and also we know that it continues to progress, and in India we are seeing that many of them are continuing to progress even beyond the age of stabilization, that we say 18 or 20. Even adult myopia is a thing where we are the thing about how to control adult progressive myopia is still not very well understood, but we know that with every diopter of myopia increase, there is going to be myopic maculopathy, glaucoma, PSCC, RD, especially we are talking about high myopia. Anything more than -6 or more than 26 millimeters will increase the risk of any of these things. That is why the axial length is important, because there may be the size of the eyeball is not the same. There may be that there's something called axial length and keratometry, they compensate each other. So you can have an eyeball with just -1, 1.5 diopter myopia, but axial length will be nearing 25, but their K reading will be flat. But since the axial length is the most important predictor for myopia progression, myopia complications and maculopathy and other things, so it is important to document. And also we are going to improve the quality of life of the child, definitely reduce the complications, and parents are definitely eager to invest in treatments that protects the child's future. So it depends upon the way they are explained, and so that comes a question of chair time. So how much time? It may not be only the consultant's time, it can be even the counselor who is being trained in that manner to sit and talk to the family for some time. It definitely creates an exciting and meaningful career. So I think this post-lunch session with a full hall, I think it definitely mandates more discussion. So initially we were thinking about how to introduce, and the DIMS had just come into the market, though it was not available in India so freely. So we were attending some meetings abroad and we came to know about these glasses, but at that point it was like during COVID we couldn't introduce. But we were having some discussion, and then we started with the Zeiss team with the MyoVision. Was the thing that we started initially. But as we all know, the response was not very good. So after some time, it was totally replaced with MyoCare, and Hoya came in between. So the first myopia clinic was established in June 22 in Aravind, Coimbatore, and at that point, it was the first of its kind center in Coimbatore. And so when we set it up, there were no clear guidelines that at that point, 21, 22. So we had to update our knowledge, survey the patient base. So once we set a clinic, how many patients are going to come, train your staff, set up the workflow, invest in some equipment, study the results and ensure compliance. So I think this will be the common steps for everyone. So updating the knowledge is definitely, there was a lot of discussions during COVID, the webinars had come, and there were a lot of discussions on this regard, and a lot of publications were coming in slowly. So we need to attend like evidence-based research and meetings, non-commercial websites, and don't go by what the company people are going to come and say, because each one will say theirs is the best. And we have to have our own way of analyzing the results, and then we convince ourselves, then we can convince the parent and the family. So around 10 to 15% of the number of patients who are walking into any practice, whether it is high volume or less, even if you say 10 patients, 1 or 2 are going to be myopic. If you see 100 patients, some 10 are going to be myopic. So that is the percentage, and pre-myopia they have already defined. So the initial days it was going very slow. We are thinking of we have introduced the glasses, and the number was very less. We had educated our department. We have 6 or AS consultants, and we have a couple of fellows. We told everyone, okay, once you see myopia patient, please advise the lenses. Nobody advised, because it was so new, it was so different, everybody was afraid, they didn't know what it is. Like suddenly you are telling to advise something, they will see, as you can see, it is 2, 4, I think these were the ones which I have given, the others were 0. Okay, so then what to do? Okay, then we have to show them one patient, we have prescribed the glass, come after 1 week, they are happy with the glass, at least their parents are not, it is visually the same, because nobody knows anything about these glasses at that point of time. And then we thought, okay, then I thought, okay, I will go and sit inside myopia. I am a passionate strabismus person. I had to give up strabismus for 2 years almost, go and sit in the myopia clinic and set up the protocol for everyone to get confidence to start myopia management. Then I had to train the refraction person, because we had to do the MEM, do the binocular vision assessment, not all the steps, a few steps which are mandatory for myopia control, and train the manager, train them for counseling, set up the steps, and then we created the myopia inside the EMR, because once the patients are registered into EMR, then we told the inclusion criteria to the refraction. The first step is they go to refraction. So ours is high volume center. So once the refraction people know the criteria, then we want ages from 6 to 14 only initially, and we want the myopia who are not like pathological myopia, who are not keratoconus patients. So all these criteria we told them, and so they are directly from the pediatric refraction they were put into myopia. So at least the patients were named as myopia clinic patient. From then we started plant the seed early with the parents. So when they will be sitting for other investigation, somebody will talk to the parent, and then so whom to treat. 6 to 14 we started as active control, simple myopia or not to a pure astigmatism. Cylinder should be stable. If there is any doubt, do a topography, and definitely there is insufficient, there is no evidence to treat pathological myopia. We see many patients coming with the just plain astigmatism with atropine. So now we say we are going to treat pre-myopia, but have you the evidence? Has that patient shown an increase in axial length at least? How do you know that that is a pre-myope? So many patients may be just remaining as just a cylinder, they will not progress. So unless you are having a family history or you are documenting that astigmatism patient is having increase in axial length, I would not think just because it is there we should not prescribe. Okay, then myopia with glaucoma, prematurity, yeah, you can, provided there are no other issues. With a cylinder, like there will be 0.25 sphere with -4 cylinder, that may not be a good candidate for myopia management spectacles. Definite indication, young age of onset. One of the most dangerous myopes are young age of onset. You have a -2 at the age of 6. Take that family very seriously, because they are going to look at the things that are going to be most meaningful if you are going to not let that myopia progress beyond -4 or -5. So you can avoid all the complications. Strong family history, both parents, one of them post LASIK, and all that you have to take into consideration. Then we developed the checklist, like in the time, so our clinic was building up and we didn't have time to ask, because once you start question about family history, they will all start talking, parents, and they will talk for half an hour, like they are not listening, I tell them not to watch the TV, so they start in that line, then our clinic will not finish. So we started giving the checklist, okay, you fill up all these things and then we will see. So we gave the thing, and then we started to stratify the risk for progression, like we just made a low, medium. See, you can have it in a better way, but our EMR is not geared for research. It is, I think in most of the clinics is like that. So if I going to ask like AI related things, they are not going to give it. So we made a simple risk stratification for progression and just put a number of points, so that because clinic is having more than 10 or 12 doctors, everybody should be in the same page. Otherwise, patient will get confused. The equipment needs are, I would say having a non-contact axial length is mandatory for managing myopia, except like, okay, some private practitioners, maybe it may not be there, but if it is there, then if it is in the vicinity, definitely use it. if you are in a tertiary eye care or any institute where they are using a biometer for axial length in cataract clinics, you can use the same thing for measuring for your clinics also. It is definitely a specialty service, and these are the tests that we do. The binocular, now we have simplified this, only 4 out of all this is completely required. And this is the, then we had set up that history inside the EMR, like now it is coming within the EMR, all the history, because so many number of pages are getting lost, and in the future if we want to do any study, we can get it as a printout. Then while they wait, all the counseling, document the progression, test roll of axial length, as we have already said, because it will give you 2 or 3 more parameters by which you can judge. Benchmark the efficacy of any treatment is, like if between the intervention group of 0.25 diopter per year, they have regarded as clinically significant. Then treatment objective is to slow the rate. See, definitely it's not going to stop the eyeball from growing. So that is what you need to impress upon the parents, because it is going to make it the same as emmetropic progression. There definitely is going to be a power change, because they are investing so much doesn't mean that they are going to maintain the same glass for 3 or 4 years. That is impossible. Impact of environment is already said. I think yeah, these things we can leave it. The target progression we have kept as for the younger age group less than 0.5 diopter per year, and in the older age group less than 0.3 or 0.25 per year is what is the target. Similarly for the axial length also. And then we made a new workflow. So this is how the patient flows through: refraction, A scan, binocular vision, then the doctor evaluation. Then for review patient, we may not dilate, like if demand every 6 months, if it's high myopic, okay, yeah. Otherwise, if there is no power change, we may not dilate also. And this is how the refraction, the workflow. So with all these, we were seeing an increase in the number of patients, and the patients and other doctors also got confidence to prescribe and follow the myopia management. Now I think it is okay. It has been 5 years now. I think so many forums have talked about the same thing, and I think even the junior most fellow also is quite confident to prescribe myopia management. So, and then you need to have some coordinator if you are looking at large number of patients, because it needs a lot of hand holding, especially with regard to some lens orders and modifications. Sometimes they did not get it very soon, all those things. And then we did a lot of research activities also with people visiting our clinics, and we had a lot of learning, especially like Dr. Padmaja from Zeiss group. They were very supportive in the initial. And we also set up myopia clinics in other, like first it was Coimbatore, then went to Madurai, then Chennai, then other Aravinds, we have replicated the same, and also in some of the other hospitals who requested, we have done the same. And a lot of awareness activities, even last week was the awareness activities carried out, and academically we had a lot of
sorry,
inputs.
ma'am.
Yeah, thank you. So that's it.
Thank you so much, dear instructors, for those excellent talk. I invite Meena Madam to hand over a small token of appreciation to Sandra Madam. Thank you to the dear audience. Post-lunch session, full hall. I'm really glad. I hope all of you get a simplified version how to manage myopia well. We'll have a small photo session. Dear faculty, please.